What's up, everybody? It's your boy Teddy V, DMP, CRNA, coming to you guys from beautiful Raleigh, North Carolina. It's Tuesday, June 29th, about 6:15 a.m. And this is day in the life of a CRNA. So let's get to it. Our chariot awaits. Alright, so a little bit about myself. I work with the diversity organization since 2015 when I was at SRNA. I'm currently work as the co-chair for the HBCU tour. I'm very proud HBCU grad. Attended North Carolina A&T, graduated my BSN in 2008. Then I went to Duke University for nurse anesthesia school. Graduated from there in 2018, and I've been here at my current hospital since October 2018. So today, in particular, I'm working in OB. I also have a student, so I'm gonna try to show you guys as much as I can the ins and outs and kind of the flow of the day and how things kind of go for me on a regular day. We have a very, very busy facility, so hopefully it's not too crazy today, so I can show you guys some good stuff. And yeah, hopefully you guys enjoy it. All right, cool. All right, man, so we're here. Hope you guys enjoyed the scenery. It's kind of foggy, kind of cloudy outside today. Normally we have the most beautiful summer days, not so much today. And we normally have about a 25-minute commute to work. Normally just try to use the commute, man, listen to some music, decompress, think about what I gotta do today. Mentally just going over stuff in my head. It's an old habit from being in school. Replaying the surgeries in my head. If there's any sick patients, thinking about different medicines we need to give, or maybe alternative anesthesia techniques, whatever the case may be, to get the job done. So I'll see you guys inside in a little bit. We're gonna hit the locker room, clock in, and get dressed. See you guys in a second. Alright, so all dressed, all ready to go. It's about 7 o'clock sharp. 3 sections a day, and normally we just do the sections. Anesthesiologist does the epidurals. And what's up, Tony? What's going on with you? So I have 3 scheduled C-sections, but there's one left over from night shift, so I'm gonna head up and relieve night shift before starting my scheduled sections. And yeah, let's get to it, see what we can see. If I get a chance, I'll come back in and show you guys the setup and how we set up for our C-sections and get ready for them. All right, see y'all guys later. All right, guys, so like I said, there was an urgent section called. What up, Corey? What's good, man? Urgent section called overnight. Just came out of that one, had to finish the section left over from night shift. It's about 8:20, so now it's breakfast time. All right, just finished a nice breakfast. It's about 8:40. My next case is at 10 a.m. So I'm gonna go ahead and get set up over there. Oh, also got a new friend here. Tanya, say hello.
Hello. How's it going?
Greetings from Brazil, Sao Paulo. She's a second year?
Second year, yep. Going on third.
Second year, soon to be third year student. And we're hanging out today. So we're gonna get upstairs, try to show you guys how we set up, and just give you guys a little game, a little theory, talk some OB anesthesia. All right, see you shortly. All right, so we've considered and seen our first patient. So let's talk about this ERAS protocol we have here, okay? ERAS, everybody knows, recovery protocol. So for OB. All right, so we'll get the patient in. She's gonna walk to the other side of the bed. I usually drop the bed. They take care of the times. They'll do the times for us. And then at that point, I go ahead and kind of position myself behind the patient, get my stuff ready, at least open it. What I like to do is I open up the cover or the packaging and put the packaging on the bed and use that as my trash can, and leave the actual kit itself on the Hollister.
Okay.
And don't even do cardiac monitoring. We'll just do oxygen, of course, oxygen, end-tidal, SpO2, and blood pressure. So I typically put the blood pressure cuff for 3 minutes, but once the spinal goes in, I change it to Q1 until we verify what level she's at. And they'll do an anesthesia timeout. Everybody be here, ready to go. We'll start the process. We'll get the spinal in. After that, we quickly lay her flat, and then we go ahead and put the leads on her, and we start the process. So you get your NTEF up front, and then also I go ahead and do my Zofran up front too.
Yeah, I was gonna ask you to do that before this point.
Yeah. So you can do it. You can do it before. Typically, I wait, and I go ahead and have my Neo plugged in as well. Go ahead. And typically, I start the Neo about 50.
So you have it ready.
Yeah. That kind of helps fight off the sympathectomy and the hypotension, et cetera, et cetera. A lot of people question if Zofran is even safe for pregnant patients, but yet think about it. When a mom has hyperemesis gravidarum, it goes to the ED, what do they treat it with? Zofran. So it's okay for obstetric drug. We'll get her down, we'll lay her flat, and we'll start the process. Checking the level. I like to use a glove with ice and water in it. I know people like to use kind of sharp, but the thing is, if you talk about which fibers start to go first, right? Temperature is one of the smaller fibers. I think it's your C fibers, right? So they're gonna start to A fibers will start to go first. And so that would be one of the first things that loses sensation, so they'd be able to test that a little faster. Whereas with touch, motor goes last, touch is there in the middle. The mom can feel you touching her, but sometimes it's hard to differentiate between dull and sharp. She just say, I feel touch, but she can't differentiate. Whereas if you put something cold on them, it's pretty marked, because if they don't have any sensation, I don't feel anything, I don't feel anything, I don't feel anything, oh, this is really, really cold. So I try to use ice and water. That kind of helps with sensation a little bit better. All right. What else?
Do they have their own? Is this their own?
Yes, it has to be a biflow. It has to say biflow in the packaging, otherwise it won't have place for the end title. All right. So Tanya's getting set up. We just in here talking some game, and our wonderful OR here. Getting ready for our 10 o'clock section. It is currently 9:09, so we got a little time to kill. So quick review, this is our basic spinal kit. All right, we're doing spinal anesthesia, and one of the best things about being a good anesthetist is knowing what's in your kit. So you don't want it the first time you look at it to be when you open it. So here's the kit and all the components. And if I'm really looking over the kit and paying attention, I know there's no local or neuraxial anesthesia in here, so I have to draw up my own. So today we're going to use standard 0.75 spinal Marcaine. Also got some fentanyl and Duramorph we use for our spinal as well, along with lidocaine for infiltration. So you'll open your kit. This is going to be sitting on top like so, right? At this point, you've already gloved up. You check your landmarks. Another Teddy B-ism I like to do is I'll grab one of these as well. And the cool thing about this is, pop this open for me. Right? A lot of us, whenever we kind of fill in for landmarks, we like to kind of take our nail and drive it in somebody's back to kind of know where we want to stick our needle at. But once you kind of scrub the patient, that mark goes away. So let me see your hand 1 second. I like to use this kind of like this right here. It leaves a mark and you remove it. What do you have? Voila. I don't know if y'all can see that, but it basically looks like a little bullseye.
Yeah.
And whenever you scrub, it doesn't go away.
Nice.
So I like to use a little syringe here to kind of make my mark. Once I've made my mark, you'll assess the landmarks with clean gloves. And you come back, you will take your iodine, like so. All right. And what I do at this point is I go ahead and take the whole thing with my sterile gloves, brush it off, clean the area, and then toss it. Brush it, clean the area, big circular motions, and then toss it. What this does, it keeps from everything dripping by iodine everywhere and leaking down the patient's back. Clean, 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 and then toss it. Then I toss the whole thing, but I keep these. Okay? And you have your big finisher drape. Okay? You're gonna be very careful because this is sterile still. You don't want to contaminate it. What I like to do is pull this off like this, kind of like a matador. Pull it, drop it, protect it. This goes over the patient's back. Right? So now let's get to the good stuff. So you got a pink syringe and they got a blue syringe, right? So what I normally do with the pink syringe, I come over here, I draw up my 2% Lido, right? Someone will hold it for you kind of upside down like this. You drop the Lido, and this is also cool because if you draw too much Lido, a little extra, you can put it in these little cups right here. But after I draw it up with the pink, I switch to the blue. The blue's a lot thinner, we can use this for infiltration. So find your space, secret needle. And what I also do is I kind of take the needle and leave it in the patient's skin like this to kind of leave my mark. And I come back with what we call an introducer needle. And I switch places. Put the introducer needle where the local needle was. That kind of holds our spot. Drawing up your marking, use a filter needle. Typically we use 1.6 mLs for everybody. If they're shorter, say 5 feet, I'll go down to 1.4. If they're taller, maybe you have to go up to 1.8. You'll pop that, you'll aspirate that out. And this is what I was telling you about the narcotic, right? So if we have 1.6 mLs of Marcaine in here, we're going to put our narcotic. I'm going to be holding this for you. What you need to do is pour down the plunger, and I'm going to stick the needle directly into here like so.
I'll see.
There we go, and then squirt it in.
Okay.
So we do that for both our Duramorph and our fentanyl. Now that's ready. And of course, we have our actual spiral needle. That's ready as well. This is pretty standard size. Pinkin 25 gauge, 3.5 inch. For larger, more obese patients, we have several different ones to get really long. How do you like that?
Dang, that's huge.
This is a 25 gauge, 6 inch.
Dang.
And it's a quickie, so it's a cutting needle, right?
Right.
Versus a pinkin, which is a more duller tip. And difference from a practitioner standpoint, for pinkin, you can appreciate the pop at the ligament and flavum a little bit better because it's dull. With a Twinkie, you're gonna cut right through everything, so you can't appreciate it as much.
Okay.
Right? So you can say technically the cut needles is for a more seasoned practitioner. So yeah, so you get into the kit, kind of see what you see, do what you do, feel around, and get familiar, because it's gonna be your best friend for your next couple weeks of your OB rotation.
Right.
Right. Talk a little theory, right? All right, so we talked about this earlier with our first case, right? Pregnant women are notoriously known for having really difficult airways, but unfortunately, if you're going to have an adverse event, it's not going to be because of the airway. We already discussed and said it's going to be more likely relative to a hemorrhagic event, secondary to uterine atony, right? So, as anesthetist is kind of moving through the day, there's three things or three categories I try to group patients into to kind of help my thinking ahead, what I need to do to kind of get ready for that. So, it seems very simple, but it's going to work and it's going to stick with you. So you can have patients that have a sick uterus, a big uterus, or old uterus, right? These three categories are all going to contribute to uterine atony in their own way. And anytime you see any kind of pathology, if you group it under one of these three categories, it'll help you kind of process like, oh, I need to be on the lookout for this, right? So first, let's talk about a big uterus. what can make a woman have a big uterus, right? Naturally, the first one to say is an obese woman, right? But it's kind of like your bone structure. Just because you're a big lady with a lot of adipose doesn't make you big boned. Doesn't mean you have a big uterus. You have a normal sized uterus, you got a lot of excess on the outside, right?
Like women that have had a lot of C-sections that have a lot of scar tissue.
Right? So that's different. That's going to go under our old uterus. So we'll get that second. So big uterus, we talk about women who have gestational diabetes typically have larger kids, right?
Yes, and that's why she's having her C-section.
Right. So macrosomia is the word, right? Our buzzword for it. So if you see a mom with gestational diabetes, it means more than likely she has a big baby. She has a big baby, she has a big uterus. She has a big uterus, that thing try to shrink back down. If you don't shrink it down in time, she starts bleeding. That's going to contribute to the hemorrhagic event, right? So macrosomia, gestational diabetes, you can say obesity maybe. Another big one is multiples, right? One baby is cool. You got 3 or 4 in there. It's going to be a lot larger. If it's a lot larger, it's going to make it a lot harder to kind of like shrink down, right? Another one is oligohydramnios. Familiar with that? So oligohydramnios is basically mean, or polyhydramnios means you have too much amniotic fluid. So the baby's normal size, but you basically have too much amniotic fluid, which makes the uterine kind of distend and bigger than it's supposed to be. So once again, if you try to shrink back down, if she's no spring chicken or a smoker or a vascular path, she can't shrink down in time, she's gonna bleed and contribute to a hemorrhagic event, right? So that's our big uterus. Old uterus, you mentioned one, you can have what we call AMA, right? You can be your first child, you can be a G1, but if you're 40, it's considered AMA or advanced maternal age. So that's an old uterus. You have some healthy 40-year-old moms, so I don't want to group them all, but medicine says you're old for having a baby at 40. So advanced maternal age is one, and that's the same thing, just not as young, not as like elastic uterus, can't shrink back down as quickly, right? Also, you could be 22 and be a G6. So that would be an old uterus just because your uterus shrinks out and collapses back down, shrinks out, collapses back down until it can't no more. And then that wouldn't present problems for us. So also a woman with a history of a STD or anything like that, any kind of scarring, any kind of fibroids, past tumors, anything like that. Those kind of contribute to the old uterus, which means the uterus is kind of, taking a few hits, maybe not shrink down as quick as possible. So you got advanced maternal age, you got multi-parous women history of STDs or any kind of scarring from fibroids or anything like that as well. Okay? And the last one, okay, sick uterus, right? So this one is pretty straightforward. All right, so we have our abruptly open placenta, right, which is basically when it's basically detached from the wall of the uterus. We have our placenta previa, which means that the covering of the cervix is covered. So it can't be a vaginal birth, it's gonna have to be a section. Then we have our placenta procreta, accreta, increta. All with varying levels of implantation into the myometrium, which can be a big issue because once it detaches, if it takes a big chunk of uterine wall, it's a huge, massive hemorrhagic event. And then you have to kind of get into the algorithm to treat them like an MCP in some cases. Right, so those are your sick uteruses. And another one that's kind of fairly underestimated is if you see a patient that has GBS, would be strep, right? So it doesn't mean they have it, but it could put them at risk for having an infection in their amniotic fluid. You'll notice whenever we're doing C-sections, if they cut and they get clear fluid, it's supposed to be clear straw colored with the fluid. They say amniotic fluid is clear and yellow, or wheat colored, or amniotic fluid is clear. If they start seeing black or green, in addition to meconium, it can also mean an infection in amniotic fluid. GBS predisposes you to that. So let's think, what ICU did you do? No. I hope you can say NICU, it'll make it so much easier. But anyway, think about a sepsis patient, right? If a sepsis patient has any kind of like bloodborne pathogen, right, what's it gonna cause them to do? It's gonna make their vasculature vasodilate. That's why we give them so many pressors. It's gonna make them vasodilate. So think about this in case if mom has an infection in her amniotic fluid, it's gonna make her vasodilate. And since we have to try to compress it back down, it's gonna be boggy and bleeding. We want to make sure we try to get that to snap back, tighten up as possible, as fast as possible.
So for like, say this receptive from like whatever's going on with her from the infection, is the treatment for that like as a mother, like in a mother unit, would that be legal still? Would you just go to
So
neo, or...
if she's truly septic, then you would just use supportive care, whatever you need to keep her pressure up. And of course, for pretty much majority of these pathologies, probably with the exception of infection, the primary treatment is delivery of the baby.
Right, that's true. Okay.
Right.
And then the treatment for the vasodilation normally is just we go neo first and then
We go neo
right?
first, and then we can advance
Right.
and escalate care as needed. If it was really that bad, we would probably be doing her downstairs instead, just so we have more support. As up here, we're kind of like a no romance in some instances.
Okay.
But yeah, so as you kind of start to look at pathologies and you know what I mean, you see certain things, kind of put them in your head. Sometimes it can go off without a hitch, no issues whatsoever. Every once in a while you be like, okay, we're getting there, right? So let's talk about the hemorrhagic pathway for mothers, right? So we already been in one section. Everybody automatically 20 Pitocin, okay? If that's not working, she's gonna say what? She's gonna say double the pit. So we'll go from 20 to 40 Pitocin. If that's not gonna work, then she'll say, hey, now it's time for some cytotec. The cytotec, she'll either do PO or she'll do intravaginally. And we just give them the pill, and that helps. Now, another drug we can also use on our uterine tonics is a methogen and a hemabate, right? We gave hemabate earlier today, right? So the way I help remember is, right, we always talk about the name of hypothermia anesthesia, right? MH, methogen and hemabate, 200, 250. Those are the doses. For whatever reason, I don't know why, it's pretty much the same thing. They always say methogen is 0.2 milligrams and hemabate is 250 micrograms, but it's still 200, 250. It's the same thing, right?
Yeah.
Always give them IM, never give them IV. That's the first one. I try to use like a big, large muscle like the quad because it's gonna help soak it up faster because it's more vascular supply, and also they have a spinal end, so they can't feel their legs anyway.
Right.
Right?
Yeah.
Right. So that being said, methogen. What's methogen's drug class? Methogen is what we call like an ergoalkaloid, right? It's literally made from a plant that just has these really, really strong vasopressor qualities. So that being said, we want to avoid in patients who have pretty significant gestational hypertension, patients with recent cardiac disease, CAD, any kind of things like that, because it's going to cause this massive global vasoconstriction to kind of clamp everything down and make it tight. So if you have already a blockage in your LAD, and we give you this, it's going to predispose you to a cardiac event, right? So we don't want to give that. So those are contraindications for methogen. Ergoalkaloid, methogen, funny word, comes from a plant, that kind of thing, right? Hemabate. Hemabate is one of our prostaglandin antagonists, right? That's why I can precipitate asthma attack in our asthma patients, right? So think about, you ever heard of an NSAID-induced asthma attack? How sometimes, so kind of the same pathway. Aspirin, Tylenol, Motrin, sometimes they say those can precipitate an asthma attack. Hemabate works the same way. So those are strictly contraindicated in patients with asthma because, of course, it can precipitate an asthma attack.
So we wouldn't get her.
No,
She has asthma.
and a lot of times they don't know. They'll call it out, but you gotta remind them, hey, she has, it's a remote history of asthma from when she was a kid, but she still uses her inhaler periodically. We want to just go ahead and go with methogen. And one's not necessarily proven to be more efficient than the other. It's really just provide a preference. Okay? So we've given PIT, we've doubled the PIT, we did methogen, we did hemabate, we did cytotec, and she's still bleeding. Okay? So this is when it gets a little more hairy. At this point, we want to make sure we're cross-matched. We may want to ask for blood in the room. May want to assess if we have albumin, anything to kind of help keep her tanked up because she's using blood after we done went through half of our interventions. At this point, it's only really two left. The first is what we call a Bacary balloon, which is basically like, it looks like a little balloon. You insert it vaginally and you blow it up. And what it does is basically tamponides the bleeding. Yeah, it's really painful though.
I'm sure.
It puts a lot of tension on the uterus. It can be fairly painful, but it's gonna stop the bleeding. So basically it's like a big thing that's gonna hold the bleeding for you. And then the last one, worst come to worst, and it's up to us also to kind of like interject and say, hey, do we need to clamp the uterine artery and do a hysterectomy? You never want that to be happening, but if you talk about saving the mom versus saving the uterus, of course you want to take that uterus out, keep it from bleeding, and move on about everything else. Yeah, all right. So that's my lecture for today. It's Teddy B School of Obstetrics. Hope you guys learned something. Alrighty, one case down. It's about 11:08. They got me out for lunch, so now it's time to go see what's in the cafeteria. Everybody's favorite part of the day. Gee. What's up there, young fella? A lot of Chuck Taylors you talk about. A lot of Chuck Taylors there, pony boy.
Your team jackass here, you old man.
Talk about back. It is 12:35. Was about to roll back my next section, but we have another case that's taking priority. Laceration. So starting to get that together. Hey, what's up? I'm gonna jump right to it.
I didn't see any big bottles either on those, so just...
That's fine. We can just do a syringe pump instead. Make it a little easier on ourselves. Alright guys. Busy day, busy day. Just finished the last case. One more C-section to go. Let's see. It's about 2:07. So I'll see you guys after this next C-section. I'm trying to get them back pretty quickly. So we can talk about that a little later. What's up, man? What's up, Kyle? I was coming to your office to get some candy, man.
I'm here, man.
Got the door closed, bruh. Oh, my man's. My man's. These people looking out.
Restock. I forgot to restock this weekend.
To get my sweet.
Yeah.
Ooh-wee. Let me get one of them them blue boys. Hey, these little joints taste different too, huh?
The little one they do.
They
You can
do,
bite
right?
into them too.
Yeah, they go a little
softer and stuff. That's a shit lock.
Alright. Appreciate you,
Right
huh?
on, yep.
Have a good one. Yes, sir. What's up, big dog? Break time. We got it's special.
Talking to me about something?
Yeah. We actually got 3 today, y'all. Me, her, Lydia.
Yeah. Say hi.
Oh, what are you doing? Oh, we live.
No. We don't play them games. See ya. Have a good one. All right. Last C-section of the day is complete. Let's see. It is 4:30, but I'm here till 7. So let's. King. What to do? Nah, man. I'm about to slide downstairs real quick though. All right. Let's go downstairs, get a snack, see if they need me for anything downstairs. Got a nice little stop in the cases. Stop by the main office to see my homies.
Hey, how y'all doing?
And let's say what's up, guys. This is the best administration team, flipping cases in and out your room, making you go crazy all day, every day. But we still love them though. It's all good. All right, still sticking around. It's about 5:08. 2 more hours left. Go visit my techs. Some of the most important people on the NCAA team. Check them out, see what they got going on. Lando, what's good? Where David and everybody at?
Here somewhere.
Floating around?
Yeah.
Doing all right?
Yeah.
What's up? So we need to keep all our supplies. Yo, the most important guy, cluster 4 right here, my man Fitz. Say what's up to the people, Fitz.
What's up?
Hardest working brother awake man right here. Luma, ¿qué pedo? You wanna say something to the people, man? You want a day in the life of a CRNA vlog? Say what's up to me, gentes.
¿Qué pedo? ¿Todo bien?
Todo bien, sí.
Oh.
Coach, gonna talk to the people. This is number 1 tech right here, David Coach Haywood. What you got to say, Coach?
Great CRNA. Follow this man. Mentor, friend, family man, all wrapped in one.
You gonna make me blush, Coach. He ain't lying.
Seriously.
He ain't lying though. He ain't lying though. So my day has come to an end. It's about 6:30. Probably would have been out of here probably like half an hour to 45 minutes ago, but got called to a code. It's helping one of my colleagues with a transfer, and unfortunately that's part of life of being a CRNA as well. Unfortunately, everybody don't make it, but man, do your best. You know what I mean? So other than that, hope y'all enjoyed it. About to head back home. It's bad. Alright guys, this concludes the day. Back at home now. But the best part about being a CRNA.
Yes!
What's up? What's up? What's up? What's up? What's up? What's up, Mo? Oh, you want to say something to the people?
Hey, Mookie. Hey, Mookie. Mo just bit me.
Guys, you want to say something to my friends? You want to say hello?
Hello.
Alright, that's life of a CRNA. Time for some food.
Yeah.
And some basketball.
No.
Yes.
Yes. No. Yes. No. Daddy, do you like my membership card?
I love my membership card. Alright guys, y'all be easy, man. Hit me up if you have any questions. Anything I can do to help you guys. Yeah, go ahead, man. Turn TV on. I'll talk to you guys later. Peace.